Okay, so we're going to have a lot of technical sessions tomorrow, so I think that we should perhaps try and get this interactive and discussion points round about more general aspects of care. So there are two microphones, one here and one here. If people would want to ask some questions for anybody on the panel about any aspects, obviously try to keep it away from your own personal care. But if there's anything you want to direct to one of the panel members, please do so. Otherwise, we will kick off with a few discussion points. So please, could you use either of these microphones? And if you could just give your name and perhaps your background or why you're at the meeting. So there's another microphone here. If people want to come up and be ready to ask a question. Yes, please. Thank you.
Hi. I'm a previous patient of cholangiocarcinoma and also an advocate on the forum groups. And I just wanted to ask, it's great that there's all these new targeted therapies, molecular profiling, blood biopsies, but the reality still in the forums, and the biggest frustration with lots of patients is the inconsistencies depending on where you live, and the fact that the reality of all these advancements on the ground is very different. As a patient, we still can't access all these wonderful trials. It tends to be down to how proactive you are as an individual to whether you get to access any of them. So how do you see the gap being bridged? How can this be improved? Because it's great that you're doing all these things, but the reality on the ground is still very different.
So can I rephrase the question? 2/3 of patients don't have any treatment. Is it because it's difficult to treat, or is it because the NHS is not good enough? Can we have a comment from each of the panel members? John, you could start.
It's a bit of both. This can be extremely difficult cancer to treat, but in some people it is incredibly treatable, and getting and moving it on is quite clearly moving as many people to that second group as possible. And this was actually the question I was going to ask Hassan about his thoughts on centralisation. So a service for a medical thing, be it paediatric heart surgery, something like that. Things like this go wrong in the NHS the whole time. Okay, the NHS is hopeless at doing things it doesn't know what to do about. And the answer has been duplicated many times over. It's a combination of carrot and stick. You centralise and you educate hand in hand. Primarily centralisation, and that's got to do.
Magda, can you comment? What's your view on that? Where is the problem?
I agree most of it with John as well. But if you talk to other countries, they've got access much quicker. The patient can be diagnosed, have genomic profiling within a week. In NHS, it takes that long time, and why we can't speed this up. And we also, when we've introduced liquid biopsies as well, we've seen that variation as well. It's, as you say, sometimes clinicians are very active, interested in innovation, and they want to offer patients. But that's not with everyone. And again, education is important. And we're hoping this will eventually equalize the knowledge of everyone to make sure everyone has the same access. Even with lung cancer, when I've mentioned it's now standard of care, but if you look England, not every trust offers this to patients. Why? It should be all trust having at the same stage. And who takes responsibility for who is taking accountability? Maybe the patient voice, is always, I've been told, is the strongest, and maybe that's something needs to be written to the government or petitioned to make sure that we can, the leading parts to ask them to get this offered to all patients, and everyone needs to have the same access. In terms of centralization, I do agree in terms of, I also treat sarcoma patients with a very difficult cancer to treat, and we have this centralization of care for these patients, and this definitely helped. In patient management, standardized so all patients go to the big centers when they are treated, whether it's surgery or whether it's chemotherapy or other therapies, and then you've got that equal access to sort of the top, often the centralized places will have then access to clinical trials as well. And I
Okay,
also do
so-
clinical trials. So
Can we move on and get everybody's view on it? Because I think it's quite a key question. Helen, would you mind commenting on that? You've probably got more insight into this problem than anybody else in the room.
Thank you. I wouldn't mind commenting at all. The answer, which Andrea probably well knows, is multifold. And just jotting down a few thoughts is, we've got the BSG guidelines for diagnosis and treatment, but they're not mandatory. And until we get NICE guidelines, they're still going to be just some people know about them, some people don't, and they're not adhered to. There's a lack of awareness. Even in the big centres, in the liver centres where they do transplants, there's still a lack of awareness around cholangiocarcinoma. This seems to us, we haven't proved it yet, we're hoping our hospital audit might bring this forward. But in the district and general hospitals, for some reason, there's a reluctance to refer patients to knowledgeable consultants, to knowledgeable centres, and above all, time is of the essence. These patients don't have time to be being their own best. They have to be their own best advocates, but there's really so little time for them to do this, and many are missing that window of opportunity for surgery. If they get to Mr. Malik in time, or to John, to Professor Professor Davidson, they are lucky, but they're the few. And
Hassan, sorry.
go ahead.
Hassan, please. I just want to allow all the panel to give their views on the same question, if we can.
So, I agree with Helen. I think what's interesting is that the AMMF data project, which showed a lot of variability in terms of surgery, is the same for stenting, and it's exactly the same for chemotherapy. Probably worst for those two things. So it's not because this is just purely such a bad cancer that most patients aren't fit for anything beyond best supportive care. And it may be that best supportive care and good palliative care is crucial. And I was in the CNS forum yesterday, and there was a fantastic talk from one of the palliative care nurses, and and that is a really important part of the story. But when you've got variability in surgery and chemotherapy and stenting, and you've got to deal with the jaundice before you can do the operation or do the chemotherapy, then it means that there's an issue in the system. And so the question is that best addressed by centralisation, as we see with liver transplantation, for example? But what's important is that you then don't lose the local expertise, which is required to deal with the acute presentation, the acute care. So you need a hub and spoke model. And going back to the sarcoma stuff, NHS England is seriously looking at super specialisation, retroperitoneal sarcoma surgery based on this type of data that there is a relationship between volume and outcome. And so in other cancers, that conversation is happening, and often driven by the patient charities and forums.
Okay.
Can I follow up on that topic? I think it's really important, and I think the answer to your question is what is being mentioned about centralization, but we cannot centralize everything because some things are really urgent and you cannot travel 100 kilometers for... Wait, John. You cannot always travel 100 kilometers. So we did a workshop 1 month ago, more or less, on as part of ENSCA, which is the European Network for the Study of Cholangiocarcinoma, that we will hear about it a little bit more tomorrow. And the workshop was about centralization of care, acknowledging that we cannot centralize everything, but what should we prioritize to centralize? And we are actually working on a manuscript that will summarize everything that came up in the workshop, and something that was constant was that what you can centralize is the decision making. So maybe a central entity that will make those decisions will avoid the patient worrying, the patient moving, the patient traveling, and it's actually, I think, the doctors who need to talk to each other. I think we need to talk to each other more. And I think it's part of our responsibility. So I will centralize especially the decision making and then see what really has to make the patient travel.
I was about to say exactly that. At the Westminster meeting we had in February, thank you. We openly discussed this, and you have to set this need to centralise against the background of the new National Cancer Plan, which is actually treatment closer to home. And how do you marry up those two? Those two. I think medical need versus political desire. I don't know.
Okay. Are there any other questions, or do you have a follow-on question?
Sorry, I've just got one more that
Okay.
probably would suit your panel as well. Obviously, some people can't have surgery straight away, which is every cholangiocarcinoma patient's dream is to get the surgery. They deem that as the best outcome they could possibly get. But with more people having the chemotherapy first with the durvalumab, and there doesn't seem, again, this seems to be patient-led, that they then want to see if they now could have surgery. And again, there's lots of cases on the forums where unless the patient pushes it to be then passed back to a surgical assessment, it's not naturally happening. And in some of these cases, patients have gone on and managed to get surgery. But again, there doesn't seem to be, once you're in the system for one treatment, it doesn't seem to fall into, are they now at some point along, could we now operate on them? And unless the patient drives it, then you're left in a black hole again.
We're running out of time if you want an answer to the question. So, is the future neoadjuvant therapies? Quick response from the panel in 2 minutes, please.
And how important is to rediscuss the patient in the MDT? A second part of the question.
John.
I think neoadjuvant therapy will become standard quite soon. There's now 2 relatively reputable papers out there. With the targeted therapies, the downsizing effect, the shrinkage effect, is 2 or 3 times that of chemotherapy. I think it's going to come. Like all of these things, we will have to, keep our heads and demonstrate it in a cool and rational way before we're allowed to do it.
You could pass on that one, Helen?
Well, no, yeah, I completely agree, and I think the key thing is the rediscussion of the MDT, because things change over time. You just never know. And we've learnt this in colorectal cancer, liver metastases, and other types of cancer, and it is crucial. And the problem in the MDTs, and I think yesterday I was talking about MDT, is that often they're busy, they're overwhelmed with new patients, etc. And so we do need to have a better mechanism in how the oncology clinicians engage with the tertiary liver MDT, for example, and when appropriate patients are brought back, because the MDT resource is a valuable resource in terms of NHS time. But definitely agree. But I think it comes back to the first call, in terms of that decision making about operability versus, obviously if there's metastatic disease of presentation is different from someone who's got a locally advanced cholangiocarcinoma, which in Brian's hand may be operable, but that MDT would say no. And so I think it's important to have that conversation. And going back to transplantation, at the moment the transplant program is only open in terms of perihyalocholangia for patients with PSC. But in the future, it will be open to patients with de novo cholangiocarcinoma who are deemed irresectable by the local liver surgical MDT. And it'd be interesting to see when that case is reviewed in the transplant MDT, whether they agree whether it was not operable or not. So I think there's a bit of work to be done there.
Lovely. Okay, I think we need to break for some coffee. We will just reduce the break to 10 minutes because we are running a bit behind time, but we did want to have some discussion with the panel. I'd like to thank all the panel members for their huge contribution. Thank you very much indeed.